All right, I'm Jamie. I'm going to look at how your face muscles are working. Also going to feel your throat, and we're going to try out a whole bunch of food items to see kind of how things are going with swallowing. Okay.
Sounds good, Jamie. It's nice to meet you. I'm Kevin.
Nice to meet you. All right, so first we're going to look at the face here. I want you to raise your eyebrows up tall. Good. And then close your eyes tight for me. Excellent. I'm looking for symmetry. Good. And everything looks great so far. I want you to smile. Good. And now this time show me your teeth. Yep, perfect. There we go. Good. Now you stick your tongue straight out at me. Good. And wiggle it from side to side. Good. Do you notice any numbness or tingling in your face?
I do not.
No? Okay, if I put my fingers here, go ahead and push your tongue inside your cheek. Excellent. And over here. Does that feel the same to you?
It does.
Good, it does to me too. Go ahead and pucker your lips like you're giving someone a kiss. Good. And then puff up your cheeks like you're blowing up a balloon. Yep, and hold it. Good, and relax. Good. I'm going to peek a little farther in your mouth. Okay? So I'm going to use my flashlight here. Open. Good. And you're going to say, ah. Good. So I'm looking at just the mucosa in the mouth. I'm looking for symmetry and the rise of the palate. Looking for how the uvula lays. In this case, Kevin has a very nice and symmetric, good elevation. That tells me about velar pharyngeal rise. And then next I'm going to now feel your throat, if that's okay.
Yeah.
So here is where we look at laryngeal rise and tilt, so the excursion. So go ahead and swallow your spit for me. Excellent. And one more time. Good. It's harder to swallow when someone's watching. Good. I'll give you something that you can try. Good.
There we go.
Good. All right. So once we've determined kind of how the structures and the function of the face and neck are moving, the decision of whether to move to PO trials is determined by that. So given the fact that everything is pretty symmetric and strong, I would start with probably some ice chips here and have you take one, chew it. I'm going to feel for how quickly, how timely the swallow is by feeling the laryngeal elevation and forward tilt. This gives me information about how the pharynx is squeezing, how the base of the tongue is moving back, how the epiglottis is tilting down, and then listening to vocal quality. So saying E. Good, and see if you can change your pitch for me. You're gonna go from low to high. E.
E.
Good. Give me a little throat clear. Good, and how about a nice strong cough into your elbow? Excellent. So listening to laryngeal rise, pitch change, tells me how that larynx is tilting and can give information about how the larynx might be feeling down there. So a good pitch change is a good thing. So given that went well, I would move here probably to some ice cream, which is actually a thin liquid because once it hits the mouth, it melts. Good. Again. Feeling good. And say E.
E.
Good. Let's go ahead and try something a little bit thicker. So we have different thicknesses. Thin, nectar, or mildly thick, which is level 2, or honey thick, which is moderately thick, level 3. These are a strategy you can use to help reduce aspiration. They don't prevent aspiration, but they can slow down the flow of the bolus to allow a patient to swallow it easier. So let's go ahead and give a bite of nectar thick liquid door. Okay. I'm a big fan of starting with the teaspoon sip. And that's something that we can talk about later on in terms of strategies. Once we decide that you're either not super impulsive or that your swallow is functional enough to try a sip from the cup. The problem with thickened liquids is they're harder to cough out. They also have more viscosity, so they can kind of sit inside of the pharynx if you have a weak throat. So they're not really the all ideal strategy. How does it feel to swallow a thickened liquid? Does it feel more effortful?
A little bit. I guess it feels like it naturally kind of forms in the back of your throat as something easier to swallow, but I don't know. This one's not too thick. It's not surprisingly thick.
Yeah. So this one, let's try this one. This one is honey thick. Honey thick is kind of the texture that we have trouble with in keeping patients hydrated because it's viscous enough then you have to drink a lot of this in order to get enough hydration.
Yeah.
Nectar thick or thin liquids would be more ideal for a patient who is discharging home or to a facility. But this can also be a nice step towards eating, just to help strengthen those muscles, get our timing up. Good. And how does that feel? Do you feel like you have to swallow more than once sometimes, or is one enough?
Let me see. I think one's enough.
One's enough. If you have a strong enough swallow, you can usually push it through. If you have a more delayed or weak swallow, they tend to stick into the throat. So then moving on to solids, we may go on to purees or even on to chewable solids. And given you have good dentition and good symmetry, we could move right on to some chewable solids here.
Yeah.
All right, so that would be a large bite. I'm gonna go ahead and have you take just one chunk to start with,
Okay.
just to make sure that swallowing's going okay. So again, feeling for laryngeal rise. I would expect with a mixed solid texture, liquids and chunks of solids, that there would be a little bit of a premature spillage, that the swallow would then activate to swallow the thin liquids. You would finish chewing and then swallow the rest of the bolus. Go ahead and open your mouth for me. Good. So another common thing that happens for patients is pocketing. Pocketing usually occurs when there's some weakness on one side of the face or on one side of the tongue. This can be problematic, especially when the patient returns to supine. Making sure a patient is seated fully upright is one of our best aspiration precautions. Seated upright with chin in neutral position, so kind of even with the floor, or even looking a little bit down towards the knees. There's a common statement called chin tuck, which we want to avoid, which is where we really kind of squish things in. Chin tuck actually can make us aspirate more. It just really distorts kind of how the pharynx moves. So yes, this gentle look down. When a patient is impulsive, has difficulty with pocketing, or has weakness that makes them unable to self-feed, one-to-one feeding or assistance is what we usually recommend. Ideally, if somebody is just confused, making sure to let them participate in eating can be very helpful. This speaks a lot to our patients with maybe a neurocognitive decline or a dementia. So filling maybe the spoon with the right amount of food, handing it to the patient, and then letting the patient then get it to their mouth. Or even the option to do kind of this hand over hand. So our patient here would hold on, I would help them, and we would get it to their mouth, just to help with the timing, get that swallow kind of ready. They're prepared, so I'm not just feeding them, okay? If all of this is going well and we feel it's safe to start a PO diet, then we would write up these recommendations. We would talk with your primary medical team and make a plan. We would come back and keep monitoring. In terms of other precautions, so you can change texture. You can make the solid softer. You can make them more solid or harder, drier. That's going to be the hardest, versus all the way down to pureed, which is going to be the easiest. In terms of how you take the food, we talked about teaspoon. We talked about cup sips, and then there's even the option for a straw. Straws are sometimes not as ideal because you really can get a huge bolus with straws, but for other patients it's very helpful. So that's where it's very patient dependent at bedside, deciding what factors will help with their swallow safety.